Hello, everyone, and welcome to today's webinar in the Public Health webinar series on blood disorders. This webinar is presented by the Division of Blood Disorders and Public Health Genomics at the U.S. Centers for Disease Control and Prevention, also known as CDC. I'm Dr. Roshni Kulkarni, Professor and Director Emerita at the Department of Pediatrics and Human Development at Michigan State University. Now, this is like a homecoming for me because I was a former division director of the CDC's Division of Blood Disorders and a distinguished hematology consultant for CDC. I bring with me a very special person. I call her the Gene Queen, and you will realize that after you hear her lecture. Dr. Jill Johnsen, who will present on understanding factor levels and bleeding in hemophilia genotype-positive female, is an associate professor of medicine in the Division of Hematology at the University of Washington. She's also a faculty in the Institute for Stem Cell and Regenerative Medicine and a physician at the Washington Center for Bleeding Disorder. She's currently co-leading a very important study called the Hemophilia A Cohort Research Program, or HARP. So now, this is an initiative which is funded by the NHLBI, National Heart, Lung, and Blood Institute. So just some housekeeping businesses. Before we begin, let me go over some few points. Today's webinar will last approximately 1 hour. Please note that this webinar is being recorded. All audio will be muted at the end of the presentation. There will be time for questions. To submit a written question, please use the question area of your toolbar. We will respond to as many questions as possible. So we'll now begin with two brief audience polls. First, we are interested in knowing more about you. Please select your response to the poll question now. So I'm going to wait for a quick result of these polls. So that is very interesting. You can see a lot of them are healthcare providers, and we welcome healthcare providers, public health professionals, family members, and persons with bleeding disorder, industry partners, and community-based organization. Now let's move on to the second poll. Let's wait for the answer. All right, so most of you are from the United States, but we welcome people from all over the world. So let us now move to the presentation. Dr. Johnsen, welcome. Let's begin.
Thank you so much for this kind invitation to speak. And I really want to thank you for a wonderful introduction. And I'm really glad that we're talking about this important topic. I'm going to do a few things here so that I can see my slides. Today, I'm going to be talking about understanding factor levels in bleeding in females who are hemophilia genotype positive. These are my disclosures, and none are relevant to today's topic. Also, as part of the preamble of the disclosures, who is this talk for? It's for everyone. And who are the females at risk? It's anyone for whom the topics we are talking about apply. First, let's talk about some considerations in females with inherited bleeding disorders. There's important themes throughout the talk that this is relevant for. First, we're going to talk about variable penetrance and expressivity. These are terms in genetics, and penetrance means how many people who inherited a gene change that causes disease have that disorder. So in this case, how many females who've inherited a hemophilia genotype have bleeding? And expressivity is how bad is the disorder. So in this case, it's how many females with that genotype have bad bleeding versus less bad bleeding. So variable penetrance and expressivity are common in bleeding disorders and common in hemophilia, and that can make it very hard to define who's affected and how badly they're affected. We also have the problem of drawing a line between bleeding and not bleeding. It's hard to quantify bleeding in any one person. A female pattern of bleeding is particularly difficult, and it doesn't have a male comparator, which is usually how we will identify discordance between males and females in other healthcare domains. Female reproductive tract bleeding is challenging to quantify in any setting. And we have systemic biases that mean that we've almost certainly under-ascertained information about females, and we can see that in that they're significant delays in diagnosis of years to decades between the first clinically significant bleeding event and a diagnosis. And we know there are many barriers to receiving care, and those same barriers are barriers to participating in research. Additional considerations in hemophilia A and B are that hemophilia is rare. So rare disorders, it's hard to educate general medical community and general populations on rare disorders. So this leads to reduced awareness. And this also can impact our ability to do testing if you need specialized tests. And lastly, both of these genes are on the X chromosome. The F8 and the F9 genes are on the distal X. And so that means there's also an inherent difference genetically between males who usually have one X chromosome and one Y chromosome, and females who usually have two X chromosomes. So where does hemophilia fall in the spectrum of rare inherited bleeding disorders? So this is population data that was published in 2021. And you can see sort of an estimated incidence here in the red boxes of factor 8 and factor 9. There's some caveats though, in that hemophilia is very likely undercounted, even though this paper was making the case that for undercounting and looking to improve that. That is probably undercounted still for a number of reasons, including barriers to healthcare access. If the person with hemophilia is not engaged in the healthcare system, we're usually not counting them. We also have a bias towards counting more severe disease because it's probably more engaged with the healthcare system. And so then we're at high risk to miss mild males and to miss females. Here's the prevalence in 319 women in the US UDC project that Dr. Kulkarni was lead author on in 2015. And so you can see here, if you look at the pie chart on the right of hemophilia A in red relative to von Willebrand disease in blue, that the proportions are a little bit different in females. Now, some of this may have biological reason, but it does not explain the entire gap. So what is hemophilia A and what is hemophilia B? So we have clinical diagnostic definitions and expectations for bleeding, but these are largely defined by the male experience, but here's what they are. So first of all, they're rare X-linked bleeding disorders. They're caused by deficiency in coagulation factors. I just noticed there's a typo. The top line is supposed to read coagulation factor 8 in the F8 gene, and then also coagulation factor 9 in the F9 gene causes hemophilia A and B respectively. So we are taught that the primary complication of bleeding in hemophilia impacts joint and soft tissue bleeding and then bleeding with injuries and surgeries. This is the pattern in males. And as you can see, some patterns of female bleeding aren't even represented here, such as uterine bleeding. And so we are taught what is the pattern to expect by what we've experienced in males. In the picture here, you can see a little guy who's got a knee bleed, and this is what we often think about when we think about hemophilia bleeding. In hemophilia, disease severity is defined by the laboratory factor activity level, not the severity of bleeding. So severe hemophilia is less than 1% factor activity, moderate is 1 to 5%, and mild is greater than 5%. There's also another important non-bleeding complication, which is the development of inhibitors. These are neutralizing antibodies against the factor that the patient is deficient in. So these are more common in severe hemophilia, and they are also mostly occurring in males. They are also reported in males with non-severe disease, and we don't have very much understanding of inhibitors in females. although we think it's largely rare. So in 2021, ISTH SSC published guidance around the nomenclature for females in hemophilia. I've adapted it a little bit because in their schematic, it's the blue box would say a female carrier. We're going to call that person a female with a hemophilia genotype. So on their X chromosomes, they usually have one normal X chromosome and a hemophilia genotype. And then we also need to know the factor level. So critical to even entering the algorithm for nomenclature, that every female would have to know what is their genotype and what is their factor level. So everyone at risk to inherit, I'm sorry, again, there's a typo, a hemophilia causing genotype, then we need to have factor testing and factor levels. I think I have an old slide deck, so I apologize for this. So ideally, genetic testing, everyone who is at risk will have undergone genetic testing to establish the causative mutation. And genotyping is really useful clinically, and this is widely acknowledged. It can inform a diagnosis. You can use it in reproductive planning, pregnancy and neonatal management, risk of inhibitor formation, predicting disease severity, and basic understanding of mechanisms of disease. The yield of genetic testing is very high. It needs to be done in an experienced lab, but in an experienced lab, more than 98% of people who have hemophilia A or B have an identified causative genetic variant. It's important to get a complete genotype. So firstly, it needs to be done in an experienced lab. This is data that we published from the US National Genotyping Program, My Life or Future in 2022. And what we showed is that you need to be able to detect all different kinds of DNA changes. If you're changing a single base pair, you're inserting new genetic material, you're deleting genetic material, you may have an inversion which flips around genetic material. You need to be able to see all those different kinds in the methods in the labs. And in males, where we are able to more easily assign severity using the lab level, you can see that some genotypes are more predominant in severe disease versus milder or moderate disease. But we have to be able to always be able to see the different kinds of DNA changes. Another reason that it's important to get a complete genotype in females is because, as we just discussed, they have two X chromosomes. So if you have two X chromosomes, you have a chance to have more than one change in more than one gene. So usually in a female, you are heterozygous, which means you have a normal F8 or F9 gene, and then indicated by the little pink bar, the other gene may have the hemophilia causing genotype. So that's the normal case for a female who's genotype positive. But that's not everybody. Sometimes females can have only one copy of the X chromosome or one copy of that region of the X chromosome, in which case they're what we call hemizygous, and their genetics is identical to that of a male. We also have homozygosity, which means they have the same copy on both chromosomes, so they can only express an abnormal gene, or they may have a different gene change on the other copy. And each of these have implications for predicting disease severity, predicting inhibitors, and counseling for reproductive planning. Another factor that we don't measure clinically, but maybe we should, is variability in gene expression is common, and in females, it is a lot of that effect is likely from X chromosome inactivation or XCI. So what is XCI? XCI happens very early in development, and it's because our cells expect only one dose of most of the genes on the X chromosome. So in a cell early in development that has two X chromosomes, our body will turn off one chromosome or the other. They're silenced. And so the result of that is that some cells will only be able to express the abnormal gene and won't make a normal factor, and some cells are only able to express the normal gene, and those cells won't be able to make a factor. So this presumes that we have a heterozygous female, and that this, which is the most common scenario, and this is the most common scenario for X chromosome inactivation. And on average, this is about a 50-50 turning off event that kind of happens early in development. And so in most females, about half of their cells that make factor are making the abnormal genotype, and half are expressing the normal one. And the result would be about half production of that factor level. But in reality, you can have skewing of how many cells are turned on or off, and it can go all the way from turning off the normal gene entirely to all the way turning off the abnormal gene entirely. So really, X chromosome inactivation is a spectrum, and at the very far ends, we call this XCI skewing. And XCI skewing can contribute to this variation in factor levels. And we even sometimes have females who very rarely have entirely turned off their normal chromosome, and they express with more severe hemophilia disorder. So talking about the factor levels, we need the genotype, we also need the factor levels. So what are those? So hemostasis, which is achieving control of bleeding, has many steps. And we have some primary hemostasis steps, which is mostly von Willebrand factor and platelets. And then we have some secondary hemostasis steps, which is where the clotting factors come in to help form the clot and establish it and mature it. So for the purposes of hemophilia, which is factor 8 and factor 9 deficiency, this is where our tests are going to be focused because those are classically in secondary hemostasis. So F8 and F9, factor 8 and factor 9 are detectable, deficiencies are detectable using the APTT. And then we also have specific assays for these factors that we can use to quantitate them. So I want to talk about the APTT very briefly because it's a cornerstone of factor testing even today. So basically we have this classic clotting cascade of multiple clotting factors, and they come together from two different branches to go to the common pathway to make fibrin clots. So you can see here we've circled where factor 9 and factor 8 are, and this is just a little discussion, but basically in a test tube where we've taken all the cells away and we've hidden the calcium, we re-add the calcium, we re-add some other things that provoke a cell-free clot, and we measure how long it takes that clot to form. So we can see this is very easily reproducible, but what it isn't is in vivo hemostasis. This is not what's happening in your body. And so this APTT is very good at detecting factor 8 and factor 9 deficiencies, but also is susceptible. Some other things can also affect the PTT. But importantly, the history of this test is that this is largely the test that was derived from the methods that were used to first even figure out what was coagulation factor 8 and factor 9. And those were identified by studying males with hemophilia. And that history informs our current testing methods. These tests were not developed in a person who also could make a normal clotting factor from a normal gene. So coming back to the nomenclature for females with hemophilia, what are the factor levels? We've got a person with a genotype. We need to know the factor levels. And a little under a third of females are expected to have a level less than 40. And in those individuals, they are classified to have hemophilia with the same severities that we use in males using this laboratory assay that I just showed you. Less than 1 is severe, 1 to 5 is moderate, and greater than 5 but less than 40 is mild hemophilia. So we don't have the word carrier in there or any other modifier. They're simply called hemophilia with the same severity as males. If you're over 40, there's an acknowledgement that people can still be affected with hemophilia bleeding. So it's important to ask, are they bleeding? Yes or no? So the bleeding history is really important to take thoroughly, and it's also important because prior bleeding is the best predictor of future bleeding. So we need to take a full hit bleeding history. And so this is sort of an example on the left, what we teach the medical students to do. And we also have a tool called the ISTH BAT, which asks questions about bleeding in these 13 domains and then an other category. So we want to ask, are they bleeding? And so if yes, now we call them symptomatic hemophilia carrier. And if no, we call them asymptomatic hemophilia carrier. Now, importantly, everyone in this red box deserves care because they are having excessive bleeding. I would also argue that people on the right need to be educated on what is excessive bleeding, because just because they haven't bled yet doesn't mean they will never bleed. And at some point, some of the people who've been classified as asymptomatic will become symptomatic and need care. So hemophilia A carriers, which I have in quotes, we're going to talk about that in a minute, really do bleed significantly compared to females who are not carriers. So I've pulled this paper that shows a comparator of people who have a genotype to people who are normal, and everywhere there's an asterisk, it's significantly more bleeding than the control population. There are so many papers now, thank you community of researchers who are developing these data, that really compellingly show that females bleed compared to controls. And this really raises the question, should we be using the word carrier at all? So if the mother is, we've talked about mothers as carrier of a condition, and is that definition throughout the rest of medicine is that mom does not have that condition? In our field, we sometimes use carrier as interchangeable with female, and we still have that in our guidance and our nomenclature. But I've challenged us a little bit because in medical genetics, the definition of a carrier is of any disorder is an individual who has a disease-causing change in one copy of a gene, but does not have that genetic disease related to the abnormal gene. So by the use of the word carrier, we are conveying to everyone outside our field that this, and some inside our field, that this person does not have a disorder. And that is categorically false. Some females absolutely do have hemophilia, and many more have bleeding. So there was a nice review in 2021, and we've had several more papers since then, but approximately 1 in 4 females will have high bleeding scores. Some will have radiographic joint structural changes indicative of joint bleeding, excessive mucocutaneous bleeding, which is from mucous membranes, which is like nose, dental, oral bleeding, uterine bleeding, which is not the pattern that we are taught from males, is common. And bleeding is only weakly associated with factor levels. We're going to talk about that in just a minute, but we do not know why. And there is some indication that perhaps poor response to desmopressin in hemophilia A may be associated with a higher VAT score. So perhaps there's a mechanism around production or responsiveness in the setting of a hemostatic challenge, but we really don't know the mechanism. What is clear is what we do need is more data. Most of what we think we know now about females in hemophilia is from hemophilia A, and it appears very likely to be similar in hemophilia B, and we really need more information. So let's talk about this bleeding is only weakly associated with factor levels. So factor levels correlate very poorly with bleeding in females. So here I'm going to show you 2 papers where they've presented the data for people with less than 40, which is our current definition of hemophilia, and greater than 40, which is above outside the range of hemophilia. And you can see in table 3 and table 5 of this paper, and I encourage you to go read this paper, which was back from 2006, that females are having excessive bleeding in both categories. There's not enough females with levels greater than 60 to really say anything, but what is clear is 40 is not a meaningful cutoff for discriminating who has bleeding and who does not in a female who is genotype positive. And furthermore, I really love this paper from Paula James's group in 2016, also looking at females with their bleeding, and also had a really nice control group. But in this figure, what we have is distinction between less than 40 and greater than 40. You can see that people over 40 are still having excessive bleeding. And here we have on the right a plot against the bleeding score using the ISTH BAT instrument versus the factor level. And you can see that that we still have a lot of bleeding, even when factor levels are over 50. I'm also going to bring forward an example from pregnancy. So postpartum hemorrhage is a risk for someone who has a hemophilia genotype. And so in this study published in 2021, it's a retrospective pregnancy study of a single institution from 2011 to 2019, 38 females with 42 pregnancies. And so they were defined to be in the study because they were genetically positive. First of all, the postpartum hemorrhage rates were high. And second of all, postpartum hemorrhage rate did not correlate with factor level at all. So putting together the no postpartum hemorrhage group baseline non-pregnant levels of factors of 70 with this wide range. And then the third trimester averaged 142 with a wide range. And the people who did have excessive bleeding had essentially the same factor levels. The factor levels did not predict who had postpartum hemorrhage. An interesting observation suggests, though, that maybe the genotype severity could be a predictor. So they also looked at who bled and didn't bleed by genotype. So if you had a genotype that caused severe hemophilia A in a male, half of those individuals had postpartum, over half had postpartum hemorrhage. Well, if you were a female with a genotype that caused mild hemophilia in a male, about a quarter, a little between a quarter and a third did. That's still a high postpartum hemorrhage rate, but that also looks like it's possibly a difference. I want to emphasize just the spectrum. So I appreciate that the authors showed the scatter plot in the way they did. So we often talk about pregnancy, and I talked about pregnancy in this way on the left, sort of what's the average change. So usually factor VIII levels go up from baseline, but they don't achieve the levels of a normal pregnancy. So on the right is the median levels of a female with a hemophilia genotype, and on the left are the levels that change in people who don't have a genotype. So you can see that females who don't go up quite a bit, and females on average who have a genotype go up some. But on the right, you can see really this is an aggregate of many different individual differences. So what this plot shows on the right, that the x-axis starts pre-pregnancy, then proceeds through the pregnancy through the first, second, and third trimesters, and then the postpartum level was measured greater than 6 weeks postpartum. And they also color-coded them by the genotype. Did they carry a mild, which is a red square, moderate blue circle, severe yellow triangle genotype? How severe is it in a male? And you can see it doesn't help you predict what's their factor level at baseline. It doesn't help you predict who's increasing their factor levels. And so really the factor level is not as informative as we all would have hoped it would be in a female in this setting. So what we really need to do is get more information. And part of that is that we need to diagnose early, and we need to offer lifespan care. This is a cartoon from a paper we just published from the World Federation of Hemophilia State of the Arts. So basically that we would advocate that at the beginning of life, a female at risk should have genetic testing, and early in life there should be factor levels so that we can assign them based on our current nomenclature. And then as they go forward, we're going to understand more of their bleeding, and that we should also continue to measure factor levels, because in some patients, both with A and with B, the factor levels can change over time. And we also need to be cognizant of excessive bleeding, and that also goes with iron deficiency. And so there are several time points during the female lifespan which are not on the radar if you're taught hemophilia care in males. So one of those is high risk for heavy menstrual bleeding, another is high risk for postpartum hemorrhage, and another is high risk for excessive bleeding around the time of menopause. And these are just key times we need to be engaging with females, and we need to better understand what are the risks for bleeding in these settings. So we need to improve our care for females, and part of that is addressing female missingness. One of the ways that we can improve this is by increasing awareness and education, by having webinars like this. We need to educate individual patients and people living with disorders. We need to educate families and relatives. We have many families who've been told females can't have hemophilia. Clearly that's not true. We need to go back and re-educate on that. Providers need to know that females can be affected by hemophilia and excessive bleeding. And that's not only hematology and OB/GYN, but also primary care, also our ER doctors. Every point of care in the system is an issue for a female who's affected when she may be told, or they may be told, sorry, that they don't have bleeding when they do. And we also need to engage through community organizations and outreach. Every female needs to be identified as early as possible. So we need to find females at risk, and we need to identify them, and the diagnosis needs to be accurate. It must include genetics, it must include factor testing, it must include a bleeding history if we're to assign them the nomenclatures and plug them into the system. We need to recognize and treat bleeding, and part of that is believing the patient. We need to believe the person when they tell us they're having bleeding. We need to treat promptly, and we need to move to prevent bleeding. And that's challenging when we don't know how to treat normal factor levels, a person with normal factor levels who's having excessive bleeding in a disorder where we've defined treatment based upon the gap between normal and abnormal factor levels. We need advocacy that insurance companies are not going to deny care to a female because she shouldn't have hemophilia. We need access to centers and other resources so that the females are able to engage as their male counterparts would. And we really, really need research, because we've just shown you that females are bleeding excessively. It doesn't correlate with the levels. It may be because we made these tests in males, but we don't know. We need a better way to predict who's bleeding and who's not. So our research needs to be inclusive of females. When we're studying hemophilia in general, there need to be females. We also need female-focused research in all aspects of this. So it's across the spectrum. We need healthcare, we need advocacy, we need government, we need the engagement of the community, we need all the providers. It's a new model for how we're going to approach care. So with that, I want to make you aware of our new mother-baby study in hemophilia A. You can go to this website, or you can use the code. And this HARP study will study pregnancy, postpartum hemorrhage, and bleeding in females who are genotype positive, and will study the causes of inhibitors in their children with severe hemophilia A. And with that, I hope I've left a fair bit of time for questions, because I'm really glad to hear how many of you are here to talk about this important topic. So the public health webinar series on blood disorders has been brought to you by the CDC's Division of Blood Disorders and Public Health Genomics. We all are really thankful to the Hemophilia Federation of America for hosting the webinar. If you have questions, here is the email, and the webinar will be archived online by the CDC at this address. With that, I really want to thank you and open it up for questions. And I'm also happy to go back to any of the content in the slide deck.
So thank you, Dr. Johnsen, for this great presentation. We'll now shift to the question and answer section of the webinar. Again, to submit a written question, please use the question area of your toolbar. So there are already some questions, so I'm going to present this to you. One of the questions was, for the postpartum hemorrhage, was the type of delivery and age of delivery considered in the analysis?
So they gathered that data, but there wasn't an obvious difference. One interesting point about that study was that the postpartum hemorrhage rate definitions were those of the time period in which the women delivered and females delivered, and now those definitions are a little bit different. So briefly, I'm going to touch on the difference. It used to be that the route of delivery changed the cutoff for how much bleeding counted as postpartum hemorrhage. It used to be that for a vaginal delivery, it was 500 cc's, and for a C-section, it was 1,000 cc's. The current definition is all postpartum hemorrhages over 1,000, and that, but that between 500 and 1,000 ACAG considers that to be excessive bleeding. So they did consider the route of delivery in that the route of delivery was collected. So I would say that the postpartum hemorrhage rates found in that study are indicative of excessive bleeding under current standards, and some of those females definitely had excessive postpartum hemorrhage. This is not the only study on postpartum hemorrhage. There have been a few others that have included females, including one that was published early this year from the Canadian experience. It didn't have very many females, but they also had high postpartum hemorrhage rates. Without sufficient data to be able to discriminate between risk factors and things like that include, prolonged labor, uterine atony, anatomic abnormalities, where there are infections, other causes of postpartum hemorrhage, it's going to be hard to dissect out what's resulting in excessive bleeding or not. But one thing I think is probably true is that when there's going to be bleeding, these people bleed a lot longer. If you're genotype, or a lot more, if you're genotype positive, if there's some obstetrical condition that's leading to bleeding, I think that opens the door to having a postpartum hemorrhage. Another kind of postpartum hemorrhage that's really under ascertained is delayed postpartum hemorrhage. So that's the bleeding that happens after the first 24 hours, and that can go up to 12 weeks later. And that's data that we really don't have complete information on yet. And in that setting, anecdotally, sometimes that postpartum bleeding can also be quite significant. So more information is needed.
Thank you. So here is another interesting question. Should the factor levels we have as standards, which we assume are based on males, be different in females? That is lower threshold for bleeding, and maybe based on blood types. Do type O have lower clotting factors?
Yeah, so these are really, so whoever's asking this has a sophisticated understanding of the lab questions. So thank you for this question. So the labs, there's a couple of considerations in the labs, and there was a recent paper by Angela Wyand and Robert Sidonio and others suggesting that maybe a higher threshold of 50 might be useful. I think my hesitation is I'm not sure the lab levels correlate with bleeding at all. So I'm not sure moving the threshold is going to help us, because if we move the threshold higher, the normal range of people who don't have a hemophilia genotype now starts to get included significantly. So even just moving from 40 to 50, you're starting to catch a reasonable percentage of the normal population's factor level. And I think that just shows us that somehow this factor activity level isn't distinguishing between a person who's having bleeding because they have hemophilia genotype and a person who isn't. So that also suggests to me we're not probably getting data that's meaningful to distinguish between who's bleeding and who's not. So where to draw that cutoff? I think the safety in the nomenclature guidance was that there was already guidance in males, so we'll apply that to females. And then the acknowledgement was that that's not sufficient. And so therefore there was a symptom-based category without a laboratory cutoff. My guess is that hemophilia really in a female is more like our other inherited bleeding disorders where the genes are on the autosomes, which is the non-sex chromosomes, which means that usually everyone, male or female, has one normal copy and one abnormal copy. So we pick factor 7 deficiency or factor 11 deficiency. So if we think about factor 7 deficiency, the factor levels there also don't correlate well with bleeding. Factor 11 similarly. So it may be that what we think about the accuracy of our labs in factor 8 and factor 9, which are the ones we best understand, may also be the exception to the rule that in a male where there's only one gene copy, those activity labs work pretty well to predict bleeding, but in everyone else who has 2 copies of the gene, these factor activity assays aren't as useful, aren't as tight at predicting bleeding.
Thanks. And so how do we go about creating a lab that is more reflects women? Does a new test need to be created based on the women's APTT? And at the same thing, I think there's a lot of interest on one-stage assay versus chromogenic assay for doing factor levels. Your opinion on that?
Yes, so the first one is something needs to change because what we don't have is a good predictor of bleeding. So yes, I think research is needed. We need to define who's bleeding and who's not bleeding and figure out, is there a way that we can get a biomarker of a person who's going to bleed, whether it's a factor level of some kind or some other new way to ask that test. Yes, we need something because we don't have it. We need something. The question about one stage and chromogenic. So I showed you PTT-based assays, which is what the one-stage assay is based on. There's also a chromogenic assay, which asks the question of, can factor 8 or factor 9 activate factor 10 to 10A in a more controlled setting with fewer pieces and a different way to activate the factor, basically. And that chromogenic assay also has a little bit of differences in everyone about how you might get the readout of the activity level. So for example, in males who have non-severe hemophilia, we have many examples where the one-stage assay and the chromogenic assay are not the same. And it usually correlates to a missense variant where there's a change in the protein and it's just performing differently in our activity assay. And sometimes that discordance can be really big, like 20%. And a lot of the time we now think that the lower one, which is usually the chromogenic, is the one that's predictive of bleeding. And we sort of have accepted that narrative, I think, largely, that you pick the activity level that's the lowest and you kind of use that one pragmatically. So in females, it is also not uncommon to see a difference between the one stage and the chromogenic. I'm not actually sure it's for the same reason. And we also, I'm not aware of anyone who's been able to show that chromogenic correlates better with bleeding. I'm a little suspicious it may not. In my anecdotal experience, it's not obvious that it's helping me. I still have people in my clinic who are genotype positive and have both one stage and chromogenic over 40 and definitely have significant bleeding, very high BAT scores. We worry about them. So it's certainly not going to apply to everybody. And one thing that might be the case is that we built the chromogenic based upon the premises of the one stage. So it still has all of the same assumptions baked in, and I think that it's possible that it's a very different assay, but in a lot of ways it's asking the question in the same way, in that you're assuming one thing is deficient, that activity all means the same thing. We see that it doesn't between those two assays, but it has the same assumptions. Someone who's more, I would be really welcome anyone who's interested to work on this. We need to do more.
Still a lot of work to be done. So here is another question. Do you approach factor 11 deficiency in the same way as well? Which I think you addressed a little bit.
Yeah, I approach factor 11 deficiency a little bit differently, in part because a lot of the assumptions that have happened in the family are different culturally between hemophilia A and B and factor 11 deficiency. And one of the differences there is a different kind of assumption about who bleeds and doesn't bleed. There are clearly some genotypes where the levels can be quite low, but the bleeding is very minor, if at all. And there's clearly other people with similar factor 11 levels or less where they bleed a lot. I have a patient who's on prophylaxis. Well, we have a patient in our clinic who's on prophylaxis for their very low factor 11 level. So there's been a narrative in thrombosis that factor 11 deficiency doesn't lead to bleeding and that this might be a target for anticoagulation. And I would say that's not the case. This used to be hemophilia C. Clearly, people with 11 deficiency can bleed, but similarly, we don't have a great correlation between the level and how much they're bleeding. And in those cases, we use how much they're bleeding to determine treatment.
So here's another question is, do levels of factor change with age in women and girls with hemophilia? And what is the associated bleeding risk, especially in menopausal or postmenopausal women?
I think we want this question and answer period to turn into all of the research questions we need to ask. So we don't know. We don't know the answer, but here's some speculation. So in people who don't have a genotype, factor 8 levels do change over with age, and it's largely thought to be because von Willebrand factor is going up. Von Willebrand factor, which is another clotting protein in blood, stabilizes factor 8, and so it's thought that it's dragging the 8 up with it. We think now that some of the reasons von Willebrand factor level goes up is because you're acquiring other conditions that are a little bit inflammatory or inciting your blood vessels to be a little bit unhappy. So if you're getting cardiovascular disease or you're having chronic immune conditions, all of those can raise VWF and factor 8 levels. So that's probably a lot of the age-related increase. So it seems plausible that some people who are female with a hemophilia genotype would have their 8 levels increase over time. We've certainly seen that in the clinic, but it's also clearly not everybody. So one possible scenario where that might not happen would be if you have your hemophilia is caused by a change in factor 8 that makes it so it doesn't interact with von Willebrand factor, then von Willebrand factor couldn't bring up the factor 8 as you get older. That said, we don't have the data. We barely have the data on females at a single point in time. The longitudinal data, to my knowledge, is largely missing. And then everybody with hemophilia B on this, who does hemophilia B work on this call, knows we know less about hemophilia B than A. Its incidence is about, if all of hemophilia is a circle, then 4/5 of that circle is hemophilia A, 1/5 is hemophilia B. And so we really don't have as much information about B, and we make a lot of assumptions about hemophilia B based upon our experience in A. And I think most of the time that's safe, but it's certainly not safe all of the time. So in females, von Willebrand factor should have nothing to do with their factor level. It's unclear that their factor levels change over time. we used to say that factor 9 levels don't change in pregnancy. We now know that's not true. Factor 9 levels definitely change in pregnancy. We also know that factor 9 levels in some settings can be responsive to hormone conditions. And we know this from a gene change that causes hemophilia B that's called factor 9 Leiden. So we know there's a hormone responsive element near the gene. And in factor 9 Leiden in boys, they start off life with very low factor 9 levels. And then when they hit puberty, that hormone responsive element does a better job expressing the factor 9 gene, and their levels will go up. So it suggests that there could be things that are going to change our factor 9 level over time. But we don't know. It's not going to be the same story as 8, though.
So we're getting a lot of questions, which is wonderful. Is X chromosome inactivation only clinical diagnosis? Is there any genetic test to check for this?
Yeah, this is a great question. So a number of years ago, Mayo Clinic folks wrote a white paper that said that everyone with an X-linked disorder should have XCI measured. And as we can see, that's taken off. Nobody does this. we aren't able to do it very easily. And to my knowledge, they're the only ones who have a CLIA approved XCI test on their lab menu. And the way that they measure it is at a gene that's an androgen receptor. There's a spot where they are able to distinguish how much one chromosome is turned off from another in about 75% of people. And then they use that as a surrogate for the rest of the X chromosome, which is a pretty good assumption. It's probably not 100%, and it also doesn't work for like a quarter of people. So almost essentially everything we know about X chromosome inactivation and how much people are bleeding or what's going on with their factor levels comes from research, because it's just not something that's done clinically. I would argue that the data suggests that this is an important piece of information to know in a female, because we want to know if their levels are very low, what's the explanation? We need a complete genotype. Is there another gene change we need to know about? Are they shutting off one X chromosome disproportionately? Do they have skewed XCI? And that's important to know for a couple of reasons. Sometimes it's random. Sometimes it's not random. You can inherit skewed X chromosome inactivation for a number of reasons. And if that's happening in a family, that has implications for every female in that family, and we would want to know if that's happening. So we don't really have an accessible clinical test. There is one available, but it's hard to get to. I haven't succeeded in having insurance approve it yet. And I've kind of stopped asking, I realize. And then the second thing is that we need a lot more data to be able to help interpret XCI. There is a caveat to X chromosome inactivation, is that you can only measure the proportion of how much one is turned off versus the other in blood cells, because that's usually where we get the sample from. But neither factor 8 or factor 9 are really made in blood cells. Factor 8's made in the blood vessel lining endothelium, and factor 9's made in the cells of the liver, hepatocytes. And we do know occasionally that the females are mosaics, like they're a patchwork of balance of how much is turned on and off in different tissues. So in most females, the blood XCI level probably correlates with everywhere else, but occasionally that's also not true. And the only way we're going to get better at this is if we do it more.
So here's the thing, Dr. Johnsen, what would be the proper term or nomenclature instead of the word carrier?
I would like to define them genetically, but I'm not in charge of picking names. And also, I think the genotype's what really matters. And I'll give another example. The counter of that is there are some males who have 2 X chromosomes. And so when it comes to hemophilia, we should put them in the same area as everyone else with 2 X chromosomes. And there are some females who only have 1 X chromosome, Turner syndrome, and they should be in the hemophilic care bucket with 1 X chromosome. Like, we can interpret their lab levels similar to a male, all of those things. And so I would advocate we find a more precise way based upon their biology. That said, everybody's used to saying carrier, and I think we do need a replacement for that. So I know that ISTH and others are are considering how do we talk about this, but part of it is education on why that term probably isn't the best, and then it will have to be input from the broader community on a word that does make more sense. But I would advocate for something that's descriptive of the biology we mean.
So is it a standard of care to test females for Turner syndrome who are hemophilia genotype positive or diagnosed with mild, moderate, or severe hemophilia?
That's a really good question. So Turner syndrome is pretty rare. It has other signs and symptoms. And additionally, when we're testing in the genotype lab, even though we're only looking at the region around the factor 8 or the factor 9 gene, we can tell if there's another gene there. So we'll work our way backwards from the clinical lab. If in the clinical lab we're told that they're female and we see 2 genes, we assume we're done. We assume they don't have Turners because they have 2 copies of the gene. When we see people where we're only finding 1 gene change, it could be because they have 2 copies of the same problem, but it could be because they've got a very large deletion or only 1. So one clue there that you need to go looking more is what's the result of the clinical genotype. There's other clues. If they're short, they may have some other physical features, this is where having genetic results returned, counseling and results returned by people who are expert in genetics is important, is to think about things in the context of why else might we be seeing hemophilia. So usually right now, it's my understanding that people aren't usually looking for Turner syndromes. There are clues in regular genotyping that can lead to this. There can also be clues in the clinic that might lead to testing for Turner syndrome. In prenatal testing, there is also a common practice to do an array for the rest of the presence of all the chromosomes, basically. So in very early life diagnosis, that data may just come in, but usually my understanding is I'm an adult hematologist, so they already come to me with Turners, is that they've usually made the diagnosis of Turners early in life based on other clues.
So here is a person with hemophilia writing, as a woman who has advocated strongly for herself and her female relatives, do you have tips on how to get hematologists to acknowledge that prophylaxis is important for women too, especially for women who have strong history of bleeding, joint issues, and when factor is given, makes her feel better? And perhaps you can also address, I think people are worried about giving factor to raise levels for thrombosis, but also the use of the newer therapies, the rebalancing and non-factor therapies for including women in clinical trials.
Dr. Kulkarni, you're gonna have to keep me on track because that's many questions and they're all really important. So the first one, I believe, was like self-advocacy. So I think coming with the evidence and is one way. I do want to say that it's patients advocating for themselves in a clinical setting. So you're a patient because you're in the clinical setting. So you're a person living with that disorder, you come in the clinical setting. Advocacy is important. Education of yourself is important. It's also ridiculous to think that you could fix all of what's broken in healthcare. So it also considerations of getting to a hemophilia treatment center if you're interacting with a community hematologist. Not all HTC providers are necessarily on the same page either. So we're all working to improve the system all the time. So arming yourself with the knowledge and bringing the information can sometimes help. It's also our job to educate our peers to improve the understanding and outreach through things like coming to webinars, but also through publications and guidelines. And then it comes to what's the need for treatment. So then we need to treat clinically significant bleeding. And I don't think there's any controversy there. If someone's excessively bleeding, we need to do something about it. And if we think they're at risk for bleeding and they're going into a scenario where they might have excessive bleeding, we should do something to prevent that bleeding. And then the next question is, what do we do? So if their factor levels are less than 40, we have clear guidance that we can just treat like we would a male. That may not work perfectly because some of the bleeding We don't know if the bleeding is excessive compared to males with that level. Dr. Herman's recently published a paper that's starting to try and ask these questions. But it does bring factor replacement on the table more easily. There's a lot of other treatments that we can also bring to bear that should be commonly considered, which are adjunctive treatments like antifibrinolytics, such as tranexamic acid, which should be safe regardless of factor level. And also if we can do things so if the site of bleeding can be addressed. So if it's chronic nosebleeds, is there a role for cautery? If it's heavy menstrual bleeding, is there a role for hormonal treatment? The answer is yes. If they're having excessive bleeding, can we do other things to stop bleeding at that site? The last part of that question had to do with factor replacement when the level is over 40. And so to be clear, it's not always safe to replace to high levels because we know that high factor levels can lead to thrombosis. And I have participated in the care of someone where they had a thrombosis when we treated with factor. So it's not never that can happen. We do have to be careful. And this is another problem we have is we don't know what factor level you're at risk for thrombosis. So it's not okay to leave people bleeding, but we also don't know what's the effective level to take someone to because their factor level is already in the range that we target for a person with hemophilia, and we don't know where the top is for safety. At that point, I think in the absence of data right now, it's shared decision making. Where do we think the risks and the benefits lie for these different interventions? And I think it's possible factor replacement can be on the level for on the table for someone who's like between 40 and 60, but we honestly don't know how to practice that safely or effectively without the other data right now. We got to get that information so that we can speed up improvement in this space.
I'm going to ask one last question because the time is almost getting there. Is genotyping for females typically covered by insurance? Are there any studies happening that provide free genotyping like My Life, Our Future?
Yeah, great question. So first of all, I don't know how to get insurance companies to always approve genotyping, but one effective document to help with this is current MASAC guidance. So MASAC says that everyone at risk to inherit that genotype or who has hemophilia should be genotyped. And we also now have the ISTH SSC guidance that requires you to have a genotype if we're going to assign you correctly to a diagnosis. So the fight, I think, is getting closer to being a regular fight for genotyping, and not just because they're female. There's now official guidance that every female should have access to genotyping. That said, not every female has access to genotyping. There is, for hemophilia A, there's currently a free program called 8Check. It's run in our lab. Dr. Conkle leads that. And so anyone, anywhere in the United States, even not in an HTC, can access genotyping through that program. So there is an eligibility section for females. So if there is good reason to think that person has inherited a hemophilia genotype or they have factor VIII deficiency and it's not because of von Willebrand disease, they are eligible to come into that free genotyping service. We don't have an equivalent right now, unfortunately, for hemophilia B. But stay tuned in the community. There's some hope that there may be new resources in the near future.
Well, we're almost coming to maybe one more last question. Can vascular issues cause bleeding disorder patients to demand more clotting factor products? Things such as metabolic syndrome.
Oh, I don't know. I can't say that metabolic.
DDA also, so as an approach for treatment of these patients. So I think we have come to the end of our talk, and I really would like to thank each one of you for joining us today. We appreciate the invitation from our colleagues at CDC Division of Blood Disorders and Public Health Genomics to present today. We also thank our colleague at the Hemophilia Federation of America for hosting today's webinar. Very shortly, you will receive your email asking for your feedback. And I think this has been really a wonderful session, very informative, something we really, really need. We really need to understand women and girls with bleeding disorders of all types. So I am all for it, And I just wanted to let you know that you will be receiving an email. And so please respond with your comments and give us some additional information of webinars that you would like to hear. And today's webinar will be archived and the content will be available on CDC's Division of Blood Disorder and Public Health Genomic website as was shown by Jill. Thank you so much for joining us today and have a great afternoon. Thank you.